Next, I invite Dr. SARATH Ravi. He'll be talking about OCT biomarkers in retinal diseases. He did his veterinary fellowship from Shankar Nethralaya, Chennai, and he is currently working in Srikant Hospital, Calicut, and KIMS Hospital, Trivandrum. Over to you, sir.
Thank you. My talk is on OCT biomarkers in retinal diseases. We look at the retinal OCT helping to identify specific retinal biomarkers that are important in visual acuity at baseline as well as indicate the prognosis to treatment. It's a non-invasive, non-contact imaging modality based on the Michelson's principle of low coherence interferometry and has got an axial resolution of 5 to 7 microns and a transverse resolution of 10 microns. The infrared light from the diode source is split by the beam splitter. It's into a reference beam and a measurement beam. The measurement beam is the one that goes into the patient's eye, reflected back and reaches the beam splitter to combine with the reference beam, and by a phenomenon called interference. And the time delay, the echo time delay between the two beams is extrapolated into the OCT scan. A normal OCT helps in visualizing all the layers of the retina, while the internal limiting membrane, the RNFL and the RP appear high reflective. The plexiform layers and the external limiting membrane appear moderately reflective, and nuclear layers are low reflective. So the different OCT patterns of diabetic macular edema, the spongy edema being the most common, and there's a diffuse thickening of the retina with hyporeflectivity at the level of the outer nuclear and the outer plexiform layer, and usually this indicates a good response to treatment. Whereas in a cystoid macular edema, you have a fluid accumulation within well-defined cyst or spaces in the outer plexiform layer. Based on size of the cyst, it could be small, medium, large, or it could be giant cyst. Usually these larger cysts are associated with macular ischemia and have a poor prognosis. And this is a giant cyst with loss of ellipsoid zone, and usually has a poor baseline visual acuity as well as a poor response to treatment. Serous retinal detachment, on the other hand, has a good response to treatment, and it correlates with the disruption of the external limiting membrane. There is a subset of patients who have a vitreomacular traction or a taut posterior hyaloid, and these patients usually require surgical intervention in addition to pharmacotherapy. The other prognostic factors include the hyperreflective foci, which are small punctiform lesions, 20 to 40 microns, the reflectivity being similar to the RPE or higher than that of the RPE, no backshadowing is present. These are OCT biomarkers of retinal inflammation and usually indicate a poor prognosis. Their number decreases with treatment. Drill, on the other hand, is a disorganization of retinal inner layers where you cannot differentiate between the inner retinal layers, and there is usually associated with a severe form of diabetic retinopathy, and there is loss of ellipsoid zone and external limiting membrane, and usually it has a poor prognosis. Coming on to age-related macular degeneration, drusen appear as undulations of the RP Brux layer with disruption of adjacent layers, whereas the geographic atrophy appears as a depression of the inner retinal layers, as the outer layers are completely lost, and RP thinning with the loss of ellipsoid zone and increased visibility of the Brux and the choriocapillaries. So OCT helps in identification of the activity of the CNVM, the location, as well as the type of CNVM. A type 1 CNVM is the one that is located below the RPE, that is between the RPE and the Brux, and you have a hyperreflective material along with subretinal fluid, and the FA showing a speckled hyperfluorescence. Whereas in a type 2 CNVM is usually located above the RPE in the subretinal space along with subretinal fluid and intraretinal fluid, and on FA it shows the classic lacy pattern of leak. Type 3 neovascularization or intraretinal neovascularization or RAP lesion usually is identified by the presence of cystoid macular edema or pigment epithelial detachment. There could be also an intraretinal high reflective lesion corresponding to the intraretinal neovascularization. Therefore, serous PEDs are usually seen as a smooth elevation of the RPE over a hyporeflective space, whereas your fibrovascular PED is an irregular elevation of the RPE, and you have a heterogeneous feature behind the detached RPE. In a hemorrhagic PED, you don't see the Bruch's membrane because of shadowing by the blood. And fluid accumulation in CNVM can occur in different compartments, and each has got a different prognostic significance. Where you have intraretinal cystoid fluid is usually associated with the poor prognosis. The subretinal fluid usually has a better prognosis and lower rates of atrophy. And presence of pigment-epithelial detachment is associated with less favorable outcome because there is an increase in the retreatment frequency. Some of the structural OCT biomarkers include the photoreceptor disruption, which is very common in neovascular AMD. There is disruption of foveal external limiting membrane or the ellipsoid zone and indicates a poor baseline visual acuity and poor response to treatment. Whereas hyperreflective foci are also seen in AMD, and these in higher numbers persisting even after treatment indicate non-responder. The other structural OCT biomarker is the outer retinal tubulation. These can be present in the outer nuclear layer, and these are seen as round hyporeflective lesions surrounded by a hyperreflective band, and also indicate a poor prognosis. There could be subretinal hyperreflective material, which could be either fluid, fibrin, or blood, or a neovascular tissue, and the height of the subretinal hyperreflective material along with the foveal location indicates a poor prognosis. RP RIP usually occurs in a pre-existing fibrovascular PED, and it could be either a spontaneous or due to treatment. It usually occurs in those with tall PEDs more than 550 microns or a large basal diameter ones. And usually the foveal involvement of the RP RIP is associated with a poor prognosis. And presence of vitreomacular traction or adhesion in neovascular AMD also indicates a poorer response to your pharmacotherapy. They require a higher number of injections, and some of these might need surgical intervention. An epiretinal membrane on OCT is seen as a hyperreflective band over the retina, which could be globally or focally adherent. It indicates the amount of retinal thickness and also differentiate between pseudo holes and true holes. This is an OCT-wise staging of the epiretinal membrane. And in epiretinal membrane may be associated with a lamellar hole, which could be a degenerative lamellar hole with a large cavitation of the outer retinal layers with a foveal bump and loss of ellipsoid zone, both indicating a poor prognosis. Whereas tractional lamellar holes can appear due to schisis-like separation between the outer nuclear and outer plexiform layers. And here the ellipsoid zone is intact. Vitreomacular adhesion and traction are two entities during a spectrum of partial PVD. In vitreomacular adhesion, the partial PVD is not associated with any change in foveal contour, whereas in vitreomacular traction, you have change in foveal contour because of a distortion of foveal surface, intraretinal structural changes, or elevation of fovea from the surface of RPE. Whereas full thickness macular holes are full thickness interruption of retinal layers at the foveal center, either due to an anteroposterior or tangential traction, and these can be graded according to the size of the hole and the presence of VMT. So coming to OCTA, Dr. Saravana has already given a brief preview of the OCTA. It's a non-invasive imaging of the retinal and choroidal vasculature using a motion contrast. Repeated B scans are taken at the same retinal location, and any change in the phase or amplitude of the scan indicates a flow of RBCs within the vasculature. So the machine actually divides this cube scan into multiple segments, and each slab is known to represent a particular anatomical layer. So this is a type 1 CNVM fibrovascular PED with subretinal fluid on normal spectral domain OCT. On OCTA, it shows a tangled web of fine vessels in the avascular complex. And this is a peripapillary CNVM, not seen well on the spectral domain OCT, showing an irregular RP and a trace subretinal fluid. But on OCTA, it shows the in the avascular complex a glomerulus or a medusa-shaped pattern of vessels. A type 3 CNVM is usually seen as a small high-flow vascular tuft in the deep vascular complex, Whereas in diabetic retinopathy, it can demonstrate the microaneurysm. However, they are less sensitive in detecting microaneurysm as compared to a FA. It can also demonstrate the areas of capillary dropout and the enlarged foveal avascular zone, and demonstrate new vessels rarely. In MACTEL, you have a capillary dilatation and tortuosity, increased intervascular spaces, and decreased vessel density in the deep vascular complex. Can also detect the CNVMs early. In a branch retinal vein occlusion, there could be enlargement of the foveal avascular zone, areas of capillary dropout, collateral vessels, and microaneurysms, as well as detect new vessels. Thank you.
Thank you, sir. An excellent talk.